decline in mortality due to COVID from 9% in April to 2% in July. We doctors have many queries regarding the treatment of COVID, but we at IMA Mumbai West, we have printed the guidelines of treatment of COVID, which has been forwarded to us from IMA headquarters. It will come in the next issue of Bulletin Image. We also know that cardiovascular system also gets involved in COVID. So remember the mantra, wash your hands, wear mask, and social distancing, which is very, very important. Ask yourself this question: a sneeze in time infects 9, and take proper precautions. Coming back to today's webinar, we have invited Professor Dr. G.S. Wonder, a senior cardiologist, to answer the unanswered questions in cardiology. May I request a senior family practice physician practicing for more than 40 years in Santa Cruz, a stalwart, a past president, and a trustee of IMA Mumbai West branch, Dr. Acute Contractor, to please introduce today's moderator, Professor Dr. Ketan Mehta. Dr. Akil, please.
Professor Ketan Mehta does not require any introduction to IMA Mumbai West. It is like introducing Amitabh Bachchan to film industry. He's so popular in IMA Mumbai West. I mean, I don't remember any conference without a lecture of Ketan Mehta in the last decade. And today he'll be moderating a great person, Dr. Wonder. I was wondering,
you're not audible.
For knowledge, we have to wander from here and there. But now today we have got great Sir Wonder. Though he's Gurpreet Singh Wonder, I'll call him great Sir Wonder. And Dr. Ketan Mehta, who has done his MD, is practicing physician at Malad, is attached to Asian Heart, and also is the president of the electrophysiology. I'm not sure which branch. He's the president of the Electrophysiology Society of India. I hand over the mic to Dr. Ketan Mehta, and he will start the proceedings.
Thank you, sir. Very good evening to all of you. At the onset, I hope that you all are safe at your place. We know that amongst this pandemic of COVID-19, it's a difficult time we all are going through. And what we planned at IMA to have a series of experts talk in different specialities, which will be utilized for the family physicians to solving their day-to-day care. And what we are planning is a series of unanswered questions in respective specialty. So today is our first series with the experts talk, and we have the unanswered questions in the field of cardiology at the family practitioner level. And I am very much proud and privileged to introduce none other than our close associate in API, Professor Dr. G.S. Wonder. Sir is a professor and head of Department of Cardiology at Dayanand Medical College and Hospital, Ludhiana. He is a product of PGI Chandigarh. Sir has almost 180 research papers, out of which 80 are in various international journals. He has presented various papers in national and international forums. He was the chief editor of the Yearbook of Medicine 2018 and Medicine Update 2018. Sir is also the editor of cardiology section of API textbook of medicine. He is also member of editorial board of prestigious journal like JAPI and Indian Heart Journal. He is also governing body member of Cardiological Society of India. He has been awarded with Dr. K. Sharan Cardiology Excellence Award by IMA headquarters in 2004. He has also been awarded Dr. B.C. Roy National Award for the year 2006. He has been the past president of Hypertension Society of India and Association of Physicians of India. Above all, he was the organizing secretary of Epicon 2014. And just to give you an idea, it won't be, unless you witnessed it, you would have not believed it. In fact, we at committee were all very skeptical how the conference will happen. It is, it is like a Kumbh Mela, and sir had done it in a place like Ludhiana which is beyond any comparison. Hats off to sir for your excellent abilities. So today we are going to discuss with you all the common issues from family practitioners. So, sir, in your vast practice at for over so many years, I would like to know what do you think would be the commonest cardiovascular disease which are seen in a general population?
Thank you, Ketan, for this introduction. It is always a pleasure to participate in any session with you and to listen to you at the API meetings. To answer your query, we actually see a lot of hypertension because we know the prevalence of hypertension is 28% of the general population. So, anyone beyond 30 years of age, 1 in 3 or 1 in 4 people has a hypertension. Then, of course, coronary artery disease is increasing, and almost the urban prevalence is 8 to 10%. So, 1 in 10 people have coronary artery disease, whereas in the rural areas the prevalence is less; it is 4 to 5%. Out of the other cardiac disorders, I would say cardiomyopathies are common. Rheumatic heart disease is on a wane because 30 years back we used to see a lot of rheumatic heart disease. Now we rarely see acute rheumatic fevers, but we do see burnt out consequences of rheumatic heart disease, the valvular defects like mitral valve disease. Then, of course, we have other congenital heart disorders. So, largely, you can say from a family physician's perspective, in the first 2 decades, we normally would see congenital heart diseases. 20 to 40 years, we would see mostly the rheumatic heart disease. And beyond 40 years, that's the time when we see coronary artery disease.
Okay, so you've given that there is a vast spectrum of diseases which a family physician should be aware. So, of course, we know that hypertension, which is so much prevalent in our country and which they are seeing. So, probably today we will restrict our talk on known hypertensive condition more on the maybe coronary artery disease, heart failure, arrhythmias, and all the things. So, sir, what happens in commonly in family practice? I'm sure all the listeners would agree. They will suddenly get a call at the afternoon, say around 3 o'clock or 4 o'clock after lunch when they are just resting. The doc, I have got last 2 3 hours sudden severe retrosternal pain, and I feel it is acidity and gas. So can you prescribe me some medicine? And that is the commonest thing. So most of this presentation coming where the patients feel it is a more of a acidity or acid peptic disease symptoms. So what do you think? Because they are just answering on the phone. So how do they approach in this patient, sir?
That's a very good question, actually, for GPs, because this kind of phone we do get, especially the general physicians, and patients will often misinterpret something what is like a heartburn in the retrosternal area. But I would say such a patient needs an electrocardiogram definitely. If the patient is having acute kind of symptoms and patient is having retrosternal burning, because during angina episode, if you do an ECG, you will pick up abnormalities. If someone has a chronic stable, like coronary artery disease presents in various manners. It can present from one end of the spectrum. Patient can be asymptomatic. You might just pick it up on a treadmill test during a routine executive test. Or on the other extreme, patients can first have the presentation as sudden cardiac death. And it is for this very reason that some people can have the first manifestation as a sudden cardiac death, that we do this executive checkup and we try to mark out who are the people who are at a higher risk. And within this spectrum, we have this unfortunate people who first present with acute myocardial infarction. These people have never had actually angina pectoris, and almost 30% of patients will first present with acute heart attack. And we all know that the time window in a heart attack to act is only 6 hours best, but it can be extended to 12 hours because the heart muscle damage occurs. And once these people have wasted 6 to 12 hours, then reperfusion therapy, all the beneficial therapies would not happen. So you can have a sudden cardiac death, you can have acute myocardial infarction, then can have NSTEMI, what we call as unstable angina. And I would say those people are lucky who have what we classically describe as angina pectoris. That is, someone walks for a distance, has a retrosternal discomfort, and when they stop, it is relieved. So 60 to 65% of people present first time with angina pectoris, and almost 20 to 25% present first time with acute myocardial infarction. Generally, if you will dig into their histories, they will give this kind of history, what Dr. Ketan, you were trying to describe to the GPs, that for 1 or 2 or 3 days before that, they would have worsening of angina, unstable angina. And it is very often that patients will have this because angina, acute myocardial infarction, what's the difference? Angina pain will persist, will be precipitated by exertion, and will persist for 3 to 10 minutes, whereas unstable angina will last for 10 to 15 minutes. And acute myocardial infarction, this, although we are all calling it as pain, it is never a pain. In fact, if we tell a patient आपको दर्द कहाँ होती है, पेशेंट अक्सर कहेगा कि डॉक्टर साहब मेरे को दर्द होती नहीं है, बिकॉज इट्स नॉट द पेन, इट्स अ फीलिंग ऑफ हैवीनेस, it is a feeling of pressure, and it is a feeling of burning, which you were describing. And anywhere from the lips to the umbilicus, lot of times patients come and they tell you it's the diffuse nature of this discomfort which actually characterizes coronary artery disease. Whenever someone is able to localize, say, point of finger, invariably it is not due to coronary artery disease, because coronary artery disease pain will occur diffuse, retrosternal, as you described beautifully. It will be like a burning sensation. And lot many times these patients get relief. They have burps when they are getting relief. So all the more reason they will attribute wrongly to acid peptic disease. So you are absolutely right that people should get an ECG in such a symptomatology.
Correct. So now here you bring out a very nice point that upper GI manifestation also is a very common presentation in a patient who is coming for the first time of acute coronary event. And it would be our message to all the listeners that please do not ignore that. Please do not take it, even though you know the patient sometimes tell us that I have a common tendency of acidity and I have a gas problem. Please don't ignore it, take it seriously. The least they can do is get an early ECG done at that point of time. So, sir, here I would like to ask you now, somebody who arranges to get an ECG done and ECG is normal. So, now, how much probability that he still can have a coronary event versus what are the other differential you will like to keep it in mind besides acute coronary syndrome?
Yeah, that's a good actually issue, because first ECG can be normal in many of these patients. That is why in triaging of an acute chest pain, if a patient has an acute, see why we are bothered about coronary artery disease is because it is the most sinister cause of chest pain, which is acute. Now, Dr. Ketan is asking about this acute severe chest pain. These are two different syndromes of acute severe retrosternal discomfort. Patient is getting bothered. And the second is, of course, the exertional. We are not talking of exertional for the benefit of listeners. What we are both talking of at this moment is a patient who has an acute discomfort in the retrosternal region, which is maybe causing some discomfort to the extent that they are having breathing difficulties, sweating. These are all signs of an acute coronary syndrome. And first ECG can be abnormal, can be normal in these people. So you must keep these patients in the triage, repeat their ECG after 3 to 4 hours. And if the features are very suggestive, then a troponin, a trop T, trop I has to be done 5 to 6 hours after they have reported with a chest pain, because not many times ECG, like people with left circumflex disease or not a very large area of myocardium in jeopardy, there can be trops which are positive, and now we have high sensitivity troponins also. But even if you don't have that, which is not, we would not recommend that for a GP setup. But certainly you should, if you have facilities, keep these people for a couple of hours or send them to a nearby nursing home where they can be kept triaged for 6 to 8 hours. Do a trop I or a trop T. Even a qualitative is fine. Quantitative is better, although quantitative report will come after some time. And if you have serial ECG, which has been done twice, which is normal at a gap of 4 to 6 hours, the drops are negative, then you can be reasonably comfortable. Then the pre-test probability is important. See, diabetics, elderly individuals, and someone who has multiple risk factors, smokers. So you have to look at the individual also. Besides the pain characteristics, you have to see what kind of a patient is. If you have a young girl, 25 to 30, has a localized pain, you can be reasonably. So besides the kind of description of the pain, it is the what type of a patient, what is the pre test or a pre-historical probability of someone having coronary artery disease, that has to be looked into. But as you said, the other differentials are someone could be having acute pericarditis, someone could have a pain because of that. Some pulmonary disorders can be there, and if someone is very tachypneic, very breathless, it could be a pneumothorax. So some of these acute, a chest X-ray would be actually warranted. Then some people can have costochondritis, what was called as Teat syndrome, and those pains can be very severe. Acute pancreatitis, we know, has been at times missed. And so if the patient has pain which is in the epigastrium, which is going to the back, then that situation you must get an amylase lipase done in these people. Acute aortic dissection is another differential diagnosis in which thrombolytic therapy is contraindicated. So that has to be kept in mind, because if you thrombolize a patient of aortic dissection, then that can be very sinister. So acute chest discomfort patient, most risky, most common cause is acute coronary syndrome. Once you have ruled that out, then it could be esophageal spasm, it could be acid peptic disease, any of those things.
Right. So, sir, here I would put it that it would be always better to overdiagnose than underdiagnose coronary artery disease,
Absolutely.
because that is something which can be saving life versus losing a life. So, as you rightly said, so would agree with it. So, sir, in today's time, now a lot of our doctors are doing teleconsultations, and they are recommending patients to have the gadgets at home. So, as the patient checks his blood pressure and vitals, so with the digital sphygmomanometer, vital parameter, will it be of help in guiding the family physician? Suppose he tells that he had a pain, and then he said, I have checked my pulse and blood pressure. So somebody who says that my pulse rate is 120 and my blood pressure is 100 by 60, those who is a known hypertensive, and vis-a-vis somebody who says my blood pressure is 120/80, my pulse rate is 70, I have got, and 30-year young girl, as you said. So will the vital parameters will be of relevance in taking some decision from family physician point of view?
Yeah, I agree with you. During acute anginal episodes, there will be tachycardia, there will be tachypnea. So, if they are doing tele consultations, the look of the patient will, there will be kind of an air hunger, there will be tachypnic, the respiratory rates will be more, they will have tachycardia. So, all these things will, even on a tele consultation, and if he has recorded, as you rightly said, patient who has a low BP, or paradoxically, even during angina, they can have a elevation of blood pressure because of sympathetic activity. So abnormalities in blood pressure, either ways, tachycardia, sweating. Sweating is a very important sign. If your patient is having sweating and has these kind of symptoms with tachycardia, as Ketan you are hinting, that should, raise the ring the bell in the mind of the family physician that I need an ECG in this patient.
Okay, so this you rightly said, because I also remember there are a couple of patients who said, I had a severe profuse sweating which I've never experienced in my lifetime. Somebody coming out with this type of statements. So even probably the what the patient describes itself also can give a clue that something presenting for the first time, or he says that I have never experienced that in the past, will definitely lead us that no, this needs to be definitely will be under consideration. Sir, you mentioned about that you would ask them to get a various cardiac biomarkers done. So you mentioned, now if a family physician has to order, sometimes patient is fussy that no, I will get the test whatever you say. but I don't want to get hospitalized right now. So you said about troponin I or trop T. So out of the two, which one you do recommend that they should go for? Whether it should be trop I or trop T?
See, I mean, Trop T or Trop I both are reasonably accurate. Both are equally fine, and these kits are available, and these are point of care. A family physician can keep them. Whosoever has facilities to keep these patients, and it's not an expensive test. Only thing is, Trops will be positive after a chest pain with a gap of 5 hours or so. So if your patient is having acute chest pain, don't expect the drops to be at that time. You'll have to keep your patient um, for a while for drops to become positive. One thing I would say that a physician should actually, if you have a phone of this kind and you are calling the patient for ECG and patient has aspirin tablet, Disprin tablet available, you should insist upon them to take this tablet of Disprin immediately, and then they rush towards the hospital. Because if you recollect, the ISIS trial showed that the benefit of early aspirin is almost same as much as thrombolytic therapy. So this is one advice you can give to these people, that sometimes we have atypical symptoms. Patients are telling us, not for the acute kind of situation that I and Ketan are discussing, but for patients who have recurrent pains, a therapeutic trial of sublingual nitrates also helps. Sometimes you can tell them, these people who come visit your OPDs, that you take a tablet of sublingual sorbitrate, isosorbate dinitrate, and let me know whether it gives you relief or not. So if they have these nitrates, many times these people have relatives who have coronary artery disease, so that can also be tried. Only thing with nitrates is they should not then stand up, because nitrates are venodilators and there can be acute reduction of blood pressure. So you have to tell them these precautions in such a situation. And as Ketan is pointing out, these patients, you must err on the positive side rather than on the negative side, because a couple of unnecessary ECGs are not going to harm your patient, but one missed acute myocardial infarction is going to cost a lot.
Right. Sir, now let's imagine a scenario where a patient having a chest pain discomfort reaches a family physician. And now we have a trend in Mumbai, at least, that a lot of family physicians are keeping ECG machine in their clinic, which I feel it's a good thing. In fact, when it was recently introduced, because those automated interpretation ECG came, there were few people were saying that your business will go down. I said no, it's going to increase, because interpretation is always machine generated, so we know it is going to. And in fact, it same thing happened. I would rather put it is a plus point that there are people who are having those ECG machines. So sir, somebody, now we have quite a few senior people who are having those machines, and then they diagnose that now this gentleman has got acute MI, so they arranges for a cardiac ambulance. So what are the minimum things they can do till the ambulance arrives and they give the charge of the patient to the cardiac ambulance? So what all things which can be offered in the family practice, in their OPD practice?
Yeah, that's a good issue, actually. One thing I would like to share with you is we have actually created a WhatsApp group of people who regularly send patients to us. And there are about 300 plus physicians who are attached with us. They send these ECGs to us whenever they have difficulties in interpretation. And we, from our department, actually share our opinions with them. And at times, I mean, the use of these very simple technologies like WhatsApp can be very beneficial, because you will have an immediate kind of an opinion from an expert. So if you are at loss to, I agree fully with you. These equipments, the automatic interpretations are invariably fallible. But if you have doubts, then it is always good to just take a picture and share it with an expert rather than having a doubt. And it doesn't, I mean, it just takes a couple of seconds or minutes to share it with somebody. So feel free to share your ECGs with your colleagues or the person that you refer to, because time is actually muscle. And if time gets wasted in this, then patient has the consequences of that. And we know 50% of patients who have to die of an acute myocardial infarction, they die before they reach hospitals, because it's the primary ventricular fibrillation, which is actually the most sinister complication of this. So we should not be wasting time, as Ketan said. Give them an aspirin tablet. Nitrates are not going to be very useful actually in an acute myocardial infarction, but there is no harm in giving them one sublingual sorbitrate, record their blood pressure, and the best thing is to make them reach the nearest hospital where they can be thrombolized. If you are close to a institution where PCI can be done, you can send them to PCI. But I would say time is more important rather than actually there isn't much to choose between PCI and thrombolysis in these people. And early thrombolysis, actually, GPs can do a big service in this. That if their patients within 3 hours, if you reperfuse, whether you reperfuse with PCI or with thrombolytic agent, the results are the same. It is in the late patients actually who come after 6 hours, between 6 to 12 hours, that thrombolysis is significantly less beneficial as compared to PCI. So send them as early as possible, or as you said, on a cardiac ambulance to the, and before they reach, if you can warn the emergency there, tell them, share the ECGs. So we have to realize that this is an emergency and trigger the whole cascade of activities that are going to happen in the hospital. So you'll be saving further time. They will be expecting that a patient of such type is coming.
Right. Here, sir, you brought a very good point about each and every suspected patient. Even if the ECG is not done, aspirin should be the mandatory thing. Even if it is doesn't turn out to be a cardiac, still there is no harm. We are not losing. But if he is a cardiac, yes, we are going to give him significant benefit. Sir, would you like to point something about entry coated versus soluble aspirin over here?
Yeah, that's a good point, because normally we use enteric coated in chronic stable angina, but as Ketan is indicating, it's the dissolvable type of Disprin tablet which will be beneficial, because the enteric coated will take time, and it is here that you want a rapid action. So there's no harm in getting half a glass of water, put that tablet of Disprin in it, let it dissolve, and let them drink it immediately.
Okay. So the message over is very clear. Please see to it all your patients receive aspirin before they even board the ambulance, which is important. And let's hope that your patient reaches the hospital safe. If it's in a tertiary care, we'll go for an intervention. If if it is acute MI, ST elevation MI, and of course, otherwise is going to manage conservatively. Now, we know the post infarct, the discharge, the patient is being managed so often at family physician level, and they have a lot of these queries about, because the common standard drugs, beta blockers, ACE inhibitors, statins, and all they are managing. There are so often questions come, sir, about that till how long they have to continue. If somebody who is on additional drug, like somebody who is on trimetazidine or ranolazine, so what is the exact role, until how long they should continue if they are following only with family physician? Is there any parameters on which that duration or, or dosage needs to be decided?
That's an excellent question, actually, and I'm very happy that you asked this, because in my clinical practice, I see some aberrations in this, because sometimes we get so much overloaded with information from the pharmaceutical industry that it alters our practices, and they become non-evidence based. I'll answer this because I really am happy that you have asked this. One thing I can say, that in the previous question, if someone has given aspirin, if you have low molecular weight heparin and you are pretty sure that there are changes, you can even give low molecular weight heparin, because by the time the person reaches the hospital, if you don't have low molecular heparin, weight heparin, and you are pretty sure it is acute myocardial infarction, then even 5,000 units of heparin can be given IV. So you can do that if you are, if you are practicing, if you have experience in this kind of a scenario. There are four agents which patients after a heart attack should be discharged with. And statins should be given to all patients of coronary artery disease. Now, when I say all patients of coronary artery disease, it means patients who are angina pectoris, who are acute coronary syndrome, heart attack patient, post angioplasty, post CABG, ischemic cardiomyopathy, ischemic heart disease with atrial fibrillation, any, even peripheral artery disease. So all patients blanket with any manifestation of coronary artery disease, they should be on statins, and they should be high intensity statins. because for secondary prophylaxis, we use high intensity statins, which means 40 milligrams of atorvastatin or 20 milligrams, 40 milligrams of atorvastatin or 20 milligrams of rosuvastatin. Because rosuvastatin is 2 times more effective than atorvastatin, and there is not much to choose between these. So we put all our patients on 40 to 80 milligrams of atorvastatin or 20 to 40 milligrams of rosuvastatin. And statins have to be continued for lifelong period, as Ketan is saying. Now, patients who are discharged after an acute coronary syndrome, say acute myocardial infarction or an unstable angina, they should get a dual antiplatelet therapy with aspirin and clopidogrel for a period of 1 year. Patients who have stabilized, even if they have had a PCI, they should get the dual antiplatelet for a period of 1 year. Now, if these patients after 1 year, they should be put on only aspirin and clopidogrel is withdrawn after a period of 1 year. So they are on a statin, they are on antiplatelet agents, aspirin and clopidogrel for first year, and after 1 year, they remain on aspirin for a lifelong period. Aspirin is no longer used for primary prophylaxis. Last year, there were 3 trials, Ascent and Ascend, and one more trial, I don't remember the name, but the 3 very large trials, all 3 published in the New England Journal of Medicine, which showed that aspirin, so the curtain is down on aspirin as a primary prophylaxis agent. So someone who doesn't have coronary artery disease, there is no need to use aspirin. But secondary prophylaxis, all patients of coronary artery disease, be it of any form, they should be on lifelong aspirin. Third agent is beta blockers. Should be put on beta blockers. We prefer long-acting metoprolol succinate, but you can use others. And the fourth agent is a ACE inhibitor. So all patients after a heart attack should be on these 4 class of drugs: statins, aspirin and clopidogrel, ACE inhibitors or ARBs if ACE inhibitors are causing cough, and beta blockers. As far as these second line agents are concerned, and why I was happy you asked this is all these, whether it is ivabradine, whether it is ranolazine, whether it is nicorandil, or it is trimetazidine, all these 4 agents are second line anti-anginal agents. They are not first line anti-anginal agents. So if your patient after MI has no angina, there is no need to put them on any of these 4 agents. And even if you have patients of chronic stable angina, it is better to put them first on beta blockers and calcium channel blockers. And then, if they are still having angina after that, then you add a long acting nitrate. That is the third step. And if, in spite of these 3 class of drugs, your patient still gets angina, then you have to choose one of these, what we call as second line anti-anginal agents, the ranolazine, trimetazidine, ivabradine, and nicorandil. They are all second line agents, and beta blockers and calcium channel blockers are the first line anti-anginal agents. Calcium channel blockers should not be given to any person who has LV dysfunction. So people with low ejection fractions, you should avoid calcium channel.
So that's a very good message, and probably those unnecessary medications which are going on maybe post plasty or a patient who is stable can be knocked off. You said very lucidly about standard therapies. Now we have seen that these are the patients who go home stable. Few of them are not willing for intervention or for a procedure where we know we have to accept them, tell them the risk, and they continue. After a few weeks or though, the family physician gets a call at the night or gets a call next morning that repeatedly while lying down I get cough. And that is the time, sometimes if the family physician does not remain alert, we know it is something is bigger is going to blast, sir. So now let's move on from the coronary artery to the entity of heart failure, sir. So here, can you tell me what are the early symptoms where patient may not be a frank breathless, which a family physician should suspect that with underlying coronary artery disease, now they should suspect that these are the patient who is going into LV dysfunction or having a early acute LVF.
Yeah, that's a very good question because it is a consequence of acute myocardial infarction. And patients who've had a large anterior wall infarction, or patients who've had an inferior wall infarction with mitral regurgitation, they can go on to have actually congestive heart failure subsequently. And as Ketan has very nicely pointed out, actually, patients, when they complain of cough in the lying down position and they are feeling better on a sitting up, every patient is not going to give you history of orthopnea of the classical type that they will say okay, they have breathlessness on lying down and the breathlessness disappears on sitting up. Some of these can have just complain of cough and they say nocturnal cough they have, and when they sit up they have to use two pillows. So then pedal edema starts happening, then they start getting dyspneic on exertion. So as Ketan is indicating, patients of coronary artery disease can go on to develop heart failure. We have two types of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So do not depend only on an echocardiogram, that on an echocardiogram you have ejection fraction is 45% or 50% or maybe even more, but your patient is complaining of breathlessness. Now, if a patient is complaining of breathlessness, with a normal ejection fraction, it could either be that dyspnea is a marker of angina equivalent, or it is due to the heart failure with preserved ejection fraction. And in that scenario, BNP levels are very anti-pro BNP or BNP levels are useful besides echocardiography to diagnose that your patient has a heart failure with preserved ejection fraction. A heart failure preserved ejection fraction is more a consequence of long-standing uncontrolled hypertension. Mostly patients of coronary artery disease of the type that Ketan is suggesting, they will be showing you heart failure with reduced ejection fraction when they will start becoming breathless. And then your therapy will obviously be different from what you are treating routine patients of coronary artery disease.
Right, sir. So here now somebody who, as a family physician who attends a call that, please come over to see my father who has become suddenly breathlessness. Now, leaving aside today's current scenario of COVID, I mean, he clinically suspects that now this patient is in frank acute pulmonary edema. Again, he arranges for an ambulance. So what are the things which a family physician can offer till he arranges for an ambulance and arranges to shift him to a hospital? So what all things he can offer to the patient in acute pulmonary edema?
Yeah, acute pulmonary edema is an acute emergency, as Ketan is suggesting to all of you. So, when you see a patient of acute pulmonary edema, before you refer them to the hospital, you must record their blood pressure. Because if their blood pressure is very high, it is a scenario where you can do something significant. And patient of acute pulmonary edema will be gasping for breath. They will be bringing out what we teach our students also, pink frothy sputum. They'll be sitting up. They'll be tachypneic, tachycardiac. And so these people actually, you must give them an injection of furosemide Lasix, 20 or 40 milligrams stat, because by the time they reach hospital, the diuretic furosemide will give them very significant benefit. Their dyspnea will be relieved. If you have provision for oxygen, you can prop them up. You can put them in a sitting up position, and you can give them oxygen. Uh, you can give them Lasix. We normally in the hospital will give them morphine sulfate, but I don't know whether it will be available for a GP or not. But by the time they reach the hospital, they will get this thing, morphine sulfate, 3 to 4 milligrams subcutaneous, and we have to give an antiemetic before that. BiPAPs will be available with a lot of family physicians, and at times high flow oxygen or venturi oxygen or a BiPAP will be beneficial. So it depends. If you are seeing that your patient is very sick, is in a severe pulmonary edema, do these couple of things and send them over to a hospital. If you can start a nitroglycerin drip, it will be worthwhile if the patient's blood pressure is high. Or even you can give a tablet of nitrates. Actually, if the blood pressure is very high, you can give 2 tablets of isosorbide dinitrate. That will acutely venodilate, bring down their blood pressures. Give them a diuretic furosemide, put them on a BiPAP or a high flow oxygen. and depending upon whether it looks like settling or not, then you can decide accordingly.
Right. So there is again, the most of the family physicians are a little bit scared of giving IV Lasix. So here the sir has rightly pointed out, please, if the blood pressure permits, please use. Definitely, there is no harm in giving IV Lasix, and don't use tablet at that point of time because it's not going to work. There will be a lot of gut edema will be there and it will not work. So use Lasix at right point of time will be said. Sir, you rightly mentioned about heart failure with preserved ejection fraction, and nowadays what happens, a lot of patients ask for a executive health checkup, and the family physician sends them health checkup, and the 2D echo routinely reports with so many patients mild or LV diastolic dysfunction grade 1, and then the patient will start asking, I am absolutely healthy, which has been still noticed, or maybe a just a impaired fasting glucose which is just observed, or a borderline hypertension which has come up, and then there is a LV diastolic dysfunction. So the question remains at family physician, what do they should answer? Is there any treatment of it, or what they should do for this LV diastolic dysfunction?
Yeah, as Ketan is implying, whenever you see an echo, stay grade 1 diastolic dysfunction, you need to reassure your patient firstly, because they feel that ventricular dysfunction is something which is very sinister. So diastolic dysfunction, which is early, elderly people can have it as such. People who have hypertension of a long-standing duration, as Ketan said, diabetics, they can have grade 1 diastolic dysfunction. So you need to look at what is the cause of a diastolic dysfunction. As a physician, you need to record their blood pressures, see whether they have masked hypertension or known hypertension or whatever, and look at their other risk factor profile. But these people, you need to reassure them, because grade 1 diastolic dysfunction does not indicate that your patient has something impending that is happening, or you need to control their blood pressures better, treat their diabetes better. That's about all you need to do in such people.
Okay, so that is another factor which you brought out. Now, which seem in the executive health checkup so often, the ECG interpretation comes to the family physician. Somebody who on the after the health checkup, the ECG shows first degree AV block. Now that's an accidental finding, prolonged interval. How does the family physician should proceed? Patient is asymptomatic, got routine health checkup done, and found on ECG first degree AV block.
Yeah.
So let's move on to this final aspect of arrhythmia and how do they proceed in this, sir?
As you said, first degree AV block does not need any attention, any treatment. It is, we call first degree AV block whenever the PR interval is prolonged more than 5 squares, 0.20 milliseconds. So if there is the ECG interpretation will come as a first degree heart block. First degree heart block only means there is a delay in conduction from the atria to the ventricle. And same is true for right bundle branch block, because many times you do an ECG on an executive health checkup, there is a right bundle branch block, and we know 2 to 3% of the general population has a incomplete RBBB, and patients will think that there is a block. The moment this word block gets written in an ECG, it kind of rings a bell in the mind of the patient. That so first degree heart block, non-specific STT changes, and this RBBB, you should be well versed with what are ECG changes which are within normal range, which need to be recorded, of course, but taken a note of as a family physician. But it does not need actually any left axis deviation. Some patients can have. So these are some of the things that you record it, keep it in your mind, because you're the family physician who has to treat them. And in fact, many times as specialists, we have to tell patients, they bring ECGs with abnormal T wave changes, and we do not have access to previous ECGs. So that is one other thing a family physician can very significantly contribute to, is that they can help us by maybe asking their patients to have an ECG in their mobile phones, so that when they go to a specialist, at least the ECG can be compared with the previous ECG.
Right. So, sir is saying very nicely, we need to see and treat the patient and not treat the report. That's very, very important message. Even when we as a clinician look at the ECG, it is never looked at in isolation. It is with the perspective of the patient's profile, which is very crucial that needs to be taken into. So, sir, here I would like to again ask you one practical scenario. Somebody, some young lady, 35-year, recently discharged from hospital with a diagnosis of paroxysmal supraventricular tachycardia. AVNRT was diagnosed and she was advised for go for an EP study. Now she is taking some time to arrange for a money and all, and in between gets a call, gives a call to family physician that now suddenly I got a palpitation, my heart rate. She has got a machine at home. My heart rate has gone to 170, blood pressure of 100 by 70. So what can a family physician do again to this patient? She is a known case of paroxysmal supraventricular tachycardia. So, by all practical means, so what are things which can be offered by a family physician for this patient?
Yeah, PSVT is common arrhythmia in youngsters. And as Ketan is saying that if a young girl comes and gives a history, you obviously know that it's unlikely to be due to coronary artery disease. So, and especially if the heart rate is 170, 180, patient is known that such a thing happened earlier, or even if it happens first time and you record a PSVT, which is a narrow QRS rhythm, which is heart rate is say 170, 180. These, as a family physician, actually Valsalva maneuvers can be advocated by you. And if the patient is at home, what you can tell them, what I do at times tell them is it's the most crude thing actually they can do if out of all this, which you and I will not make them do. They can just put their finger and touch the palate, and if they touch the posterior pharyngeal wall, they will have a vomiting sensation, and that basically you're trying to stimulate the vagal. So I at times tell them that if they have known, doesn't matter, they can just try this. But as a doctor, if they are in your clinic having, then of course you will ask them to close their nose and their mouth, and they have to blow as if they are blowing out their ear lobules. So they have to close their mouth and their nose, and they have to blow. Basically, Valsalva maneuver they have to do. And sometimes the expression that we use is we tell them that just as they can, they are, passing stool, they are trying to, so they are straining like passing stool. That sort of an advice can be, they can do it acutely, and that might, so any of these vagal maneuvers, pressure on the eyeballs, um, patients cannot do a carotid massage, but you can do it once they are in your clinics, and you can even try a carotid massage and see. But elderly people, you have to be watchful. Scenario Ketan is giving is of a young girl, but elderly people could be having carotid disease, and there can be so more than 65, 70 years. Be little watchful. Of course, you should have in your own clinics, you should be keeping adenosine or diltiazem or amiodarone, because these are some of the agents that you can use. Or you can then set SVT is not an arrhythmia, a narrow QRS, which will take away your patient. So they can easily be referred to a nearby physician. You can tell them that you go there. Somebody can pick them up and take them there. So,
Right.
because
So,
you
sorry.
cannot let the SVT persist, you have to treat it. So if you have the
Right.
facility to treat, you treat, otherwise you send them to the nearest specialist.
So, as a family physician, you all can, if in a known or diagnosed case of PSVT, obviously you can avoid one more hospitalization if you can revert that episode by yourself or by the maneuvers, which sir has very nicely said. So, before we end, the last question I can never refrain from asking about nutrients. So, sir, I would ask you, what is, do you feel the role of cardiac nutrients in various, and today's time? It is everybody is recommending. So, what is your take on coenzyme Q10 or omega 3 or tocotrienol or resveratrol or vitamin D on in the cardiac health, sir?
Yeah, this is a good question because pill burden. See, one of the whenever I speak to IMA, I always, at the cost of repetition, I always say that the role that a family physician can play in drug compliance, no amount of popularity of Ketan or me or anybody can match the confidence and the faith that you people have, your patients have in you. So I would say that I would urge upon actually all GPs that drug compliance is a very important factor. And invariably, the drugs that we write, we feel that the patients are one of the biggest problems in clinical medicine that I feel is of actually, firstly, physician inertia, and secondly, the patient's inertia. And many times there are some drugs like ACE inhibitors, beta blockers, receptor blockers. I know this is not what Ketan has asked, but this is, I cannot help but address it whenever I get an opportunity to talk to GPs. That these agents are given at times for hypertension, but they are also given at times for heart failure and for coronary artery disease. And in heart failure patients, even patients with blood pressures of 100, we still want to escalate the ACE inhibitors, the beta blockers to the guideline directed dosages. And invariably, there remains a kind of a seesaw movement between a specialist and a GP. So we should all work in unison, and our effort should be in patients who have any patient with ejection fraction less than 30% should be on guideline directed maximal tolerated doses of ACE inhibitors and beta blockers. So we should try to achieve this collectively so that our patient, see, if I give ACE inhibitor, I see that I have a patient of LV dysfunction, I have put patient on ACE inhibitor, beta blocker, a low dose of a diuretic, I feel my moral responsibility is finished. No, it's not. It will finish the day I will achieve the maximal tolerated doses. Just prescription of a drug does not suffice. Reaching the adequate dosages. Say 10 milligrams of statin I add of atorvastatin and I feel that I have done my job. No. I have in a patient with coronary artery disease, high intensity statin is 40 milligrams of atorvastatin. So these kind of dosage, reaching the right dosages, we always have to make an effort. And in that, I think a specialist and a GP both play a very unison role, and that is what can make difference in terms of long-term survival of some of our cardiac patients. What do you say, Ketan, on this? What do you feel?
Yeah, you are absolutely right, sir. And in today's time, of course, when for the COVID era, when we talk about a lot of other cardiac nutrients and all, so where
Yeah,
yes,
can you,
of course,
sorry, I
first,
forgot nutrients. Yeah, Ketan was
yeah,
asking. Yeah, what he wanted actually me to say was this coenzyme Q, whatever it is. I have never prescribed it. L-carnitine, I have never. So these are, I mean, these are some agents which are pharmaceutical driven, and they add to the pill burden, and they should all be avoided, like carnitine or this uh, coenzyme Q10 or whatever it is.
so that is what, sir. First, our primary drug should be must. There is no compromise over that. And over and above, yes, then whatever additional we want to. Sometimes our patient anything add. You always have two types of patients. Something they would like to add in every visit. So where you can obviously offer which has some benefit which is there, but not at the cost of primary therapy which is being there for it. So at the end, sir, any message from you for our family physician delegates from cardiology, any final tips which we would like to give, sir?
Well, thank you very much, firstly, Ketan, for this beautiful deliberation. The way you have actually handled these. These are actually points which, because it speaks of your grasp on the clinical medicine. Because we have to, in a very short time, actually, you have been able to get the best out of the interaction. I can see one question, sir. What is ideal heart rate? Is there any formula? Dr. Shobha Ahuja has put it. So can I answer that? Yeah.
Yeah,
See,
yeah, sir.
for normal people, heart rate could be 60 to 100. That is what we say is the normal heart rate. But people who are physically conditioned, their heart rates are less than people who are physically non-conditioned. So people who have John Bog or so, they say that their heart rates were something in mid 40s or so. So if you are a physically conditioned, regular exercising person, then obviously you will be heart rates will be low. But someone who has anxiety, someone has a heart rate of 80, 90, 100, there is no need to worry. It's a kind of a normal range heart rate. People in acute anxiety can even have heart rates up to 100, 110, 120. You actually don't need to treat it at all, but you can put them on beta blockers. I can see my very, very good friend Deepak Jumani's comment on this. Thank you. He's saying, and he's also asking what is the role of ranolazine vis-a-vis nitrates. He knows answer to this, so he's Dr. Jumani is a very close friend, and it's always a pleasure to listen to his questions. And thank you, Dr. Jumani. Minimum dose of rosuvastatin in CAD, Dr. Parimal Mehta has written. As I said, secondary prophylaxis 20 milligrams is the minimum dose. Rosuva is a brand name of rosuvastatin. Or in people who are very young, multi-vessel disease, say there is a triple vessel disease, you are treating these people medically even higher, and their lipid levels are very high, then you put them on 40 milligrams also. But ezetimibe is a very good drug. So if your patient, you are not able to achieve LDL levels, then you combine statins with ezetimibe. That's a very good combination. Thank you, Ketan, for this interaction.
Yes, thank you so much, sir. You have really given enlighten us in the family practice common cardiology tips. And in fact, today what we have seen, the cardiology part or cardiology practice at the family physician level forms a large chunk of their routine practice, and they cannot stay away from it. So they need to keep updated. Friends, this type of sessions we are going to continue every Saturday at the same time with different specialities, and I'm sure you all will be definitely be benefited out of it in your routine day-to-day practice. Our this trend was continued because of our unrestricted educational grant which was coming from InnoCare. And before the final vote of thanks which is given by IMA, I would just request Harish from InnoCare to just say few words before our IMA part is taken as a vote of thanks. Harish.
Thank you, sir. Thank you so much, Dr. Ketan Mehta and Dr. G.S. Wonder, sir. So, good evening, all the lovely participants. Myself, Harish Mehta, working as a marketing manager in the InnoCare Life Sciences company. And this Experts Talk is our first joint venture with IMA West Mumbai. And this Experts Talk, every week we are going to invite one experts like Dr. G.S. Wonder. Similarly, we'll invite experts in different specialities with the help of Dr. Ketan Mehta. And this just wanted to give you information about the company. This entire event is organized by the InnoCare Life Sciences company, and InnoCare Life Sciences company is always known for the innovative products. And similarly, we have a brand called as a T3D3 and T3LC. So I believe none of the pharmaceutical drugs are available for improving the immunity. So here for the immunity booster during this COVID situation, we are promoting T3D3 as a important brand for to fight against the COVID-19. And similarly, we are promoting T3LC in the same indication. So T3D3, which basically contains tocotrienols along with the vitamin D3 and high dose of methylcobalamin 1500 micrograms. Along with that, in T3LC, we are giving tocotrienols and L-carnitine combination. So thank you so much, Dr. Ketan Mehta and Dr. G.S. Wonder, for your lovely insight for better patient care. And from the entire InnoCare, we wish you all the best for upcoming events. And thank you so much, sir. Over to you, sir.
Thank you. And finally, the vote of thanks by Dr. Gajaria. Dr. Gajaria is there?
No, sir. Dr. Gajaria is not there.
Okay. So on behalf of IMA Mumbai West, I would really thank Professor Dr. G.S. Wonder for his lovely participation, and in spite of his busy schedule, taking out the time. Thanks to the technical team and InnoCare, and thanks to our office bearers of IMA Mumbai West. See you again next week, same time at 4 p.m. Thank you, sir. Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.